we have got two case presentation from the Department of Internal Medicine, Amritha Hospital, by Dr. Vinayak Sarma, MD Resident, and Dr. A. Gurur Raghava Lakshmi, PG Resident, Internal Medicine. The session will be moderated by Dr. RENOY A HENRY, Additional Professor, Amritha Hospital. Over to you, Dr. RENOY.
Good evening, everyone. At the onset, I would like to thank API Kochi for giving us an opportunity to present in such a forum. I represent the Department of General Medicine, headed by Dr. M.G.K. Pillai sir, and unfortunately he was supposed to co-chair it with me, but unfortunately because of a sudden flu, he could not come in today. So one thing that I see regularly is the human body per se, it's a very complex thing. But interactions with the environment as well as pathogens make it much, much more complex. I mean, we as physicians or diagnosticians, we stumble a lot when we have these difficult cases. I think we intend to present two such cases which unmasked a lot of new avenues to us, avenues for new learning, and hopefully you will like these presentations. And I'll start with the first one by Dr. Vinayak. Over to you, Dr. Vinayak.
Good evening, everyone. I am myself Dr. Vinayak from Department of General Medicine, Amritha Institute of Medical Science. I'm a PG resident, and I want to present here this evening one interesting case. I titled it as a hidden hair. We'll come to this title at the end of this presentation, why I named it as a hidden hair. So we'll start with the presentation. That the patient came as a 53-year-old gentleman. He was working as a chemist in Kuwait and later as a security staff for the past 1 year before the presentation to this hospital. So he has a background of systemic hypertension for the past 8 years. He presented with complaints of fever, cough, weight loss for the duration of 1 month, and left knee pain and swelling, restricted mobility of the left knee joint for the 3 days duration. His fever was intermittent, high grade, associated with chills and rigor, relieved temporarily with antipyretics, and mostly during the evening hours. He had a cough which was insidious in onset, gradually progressing, associated with scanty whitish expectoration, and no diurnal or posterior variation of cough, no aggravating or relieving factors, and no history of any hemoptysis. He had a left knee pain which was associated with swelling of the knee joint. It was acute in onset with a duration of around 3 days, and dull aching in character which associated difficulty in moving the joint. And there was no radiation of pain or aggravating or relieving factors regarding the pain. So personal history, he had a mixed diet with a decreased appetite, normal sleep, normal bowel and bladder habits, and no habituations. He was taking 2 medications for his hypertension, that is telmisartan and cilnidipine. He was initially evaluated in an outside hospital. The lab reports which was available, he had a hemoglobin of 12.2 with a total count of 3,100 with a neutrophils of 58% and lymphocyte of 34 and a platelet of 2 lakh and a ESR of 70. And he had a sputum gram smear, sputum culture and gene expert was tested in the outside hospital, was negative. They performed a HRCT which was showing a patch of increased density with adjacent parenchymal bands which was noted in the apical segment of left upper lobe and the posterior segment of left upper lobe, and no evidence of any calcification or cavitations, and multiple reactive pretracheal and prevascular mediastinal lymphadenopathy was present. And they was treated with multiple antibiotics. So after that also he had persistent pain over the left knee. So he was referred to our hospital for further evaluation and management. So on examination, he was conscious, oriented to time, place, and person, was moderately built man with a nourished, and he had icterus, which was no pallor, cyanosis, clubbing, lymphadenopathy, or pedal edema. The vital signs, which are pulse rate of 104 and BP of 130/80, respiratory rate of 22, and a temperature of 100.3, and saturation of 97% in room air. Musculoskeletal system examination revealed a diffuse swelling over the left knee joint with a suprapatellar and infrapatellar fullness. Diffuse tenderness was present, local warmth was there, and a flexion movement of possible up to 60 degree, and a full extension movement of was possible. System examination revealed respiratory system, upper respiratory tract was normal, lower respiratory tract, bilateral air entry was equal, normal vesicular breath sounds, and no added sounds were heard. And other system was, there was no obvious abnormality in other system. So on preliminary investigation, we had a total count of 2,360, the differential count neutrophilic predominant of 81% neutrophils, and a hemoglobin of 10.7, and a platelet count of 1,27,000 with the elevated inflammatory markers of CRP of 171 and ESR of 87, the procalcitonin of 0.3, and he had a hyponatremia of 126, and his LFT was showing a bilirubin of 2.17, and direct bilirubin which was 1.28, and a SGPT of 60, and an ALP of 258. His urine routine was otherwise normal except for a trace proteinuria, and his ferritin, fibrinogen, and LDH and triglyceride was done in view of this pancytopenia, and we want to rule out any possibility of hemophagocytic lymphohistiocytosis, HLH. So we did a ferritin which was 1,209, fibrinogen of 747, and LDH was 134, and triglyceride of 112. He had a HbA1c of 7.2. So in view of pancytopenia, we did a peripheral smear which revealed a total count of 2,000 cells with a neutrophilic predominant of 70% neutrophils, no atypical cells or blasts, and a platelet count of 1,05,000. His chest X-ray, which was a slightly rotated film, but showed no obvious abnormalities. So coming to the differential diagnosis, at this point, we want to consider like septic arthritis of the left knee, and a disseminated tuberculosis we want to consider because in view of a 1 month history of fever with the cough and these presenting symptoms, and hematological malignancy also we want to keep as a differential diagnosis in view of his derangement in the blood, that is pancytopenia, anemia, and all the persisting. So he was started on empirical antimicrobials and other supportive measures. Initially, he was started on injection piperacillin tazobactam and injection clindamycin. In view of the patient having severe left knee pain and swelling and restricted mobility, we went ahead with an MRI of left knee, which showed an abnormal marrow signal in the left tibia with marrow enhancement along with joint effusion and synovial enhancement, which showed a possibility of septic arthritis. So these are the image I want to present. So this image was MRI knee sagittal view, which was showing an effusion over the knee joint. And also this is a coronal view. I want to highlight the marrow enhancement in these both femur and tibia, which was suggestive of osteomyelitis features. So in view of this persistent fever spikes and worsening of neutropenia, his antibiotics were escalated to injection meropenem. Injection vancomycin was added for this MRSA coverage, and injection fluconazole was also added. And the left knee joint effusion showing features of possible septic arthritis. So we went ahead with an orthopedic opinion, and emergency arthrotomy and washout was done, along with left deep and superficial infrapatellar bursectomy was done, and samples were sent for culture sensitivity. So despite these empirical antimicrobials, he had persistent fever, worsening pancytopenia. So we wanted to go ahead with a bone marrow study. And unfortunately, bone marrow aspiration study did reveal a dilute marrow showing a scattered hematopoietic elements with a bone marrow biopsy, which was not inadequate to be reported. The sample was not inadequate to be reported. And we had also sent a myeloproliferative neoplasm panel. So with these inconclusive reports, we went ahead with a whole body PET CT for this further evaluation. And here I want to highlight the findings of PET CT, which showed a supra and infradiaphragmatic lymphadenopathy with a hypodense lesion over the spleen. Here is a hypodense lesion which was noted in the spleen with a heterogeneous marrow uptake both in the axial and appendicular skeleton, which was suggestive of both neoplastic and infective etiology. And also the soft tissue lesion, cavitator lesion was there in the lungs, in the upper lobe of the left side upper lobe in contact with the first sternocostal joint and mediastinal pleura, along with few soft tissue nodules, which was suggestive of infective etiology. And also I want to highlight the left knee joint subcutaneous soft tissue stranding with a joint effusion. So meanwhile, his blood cultures, 2 samples, and tissue culture, which came out to be positive for Burkholderia pseudomyeli, which was sensitive to the antibiotic he was on, and it was actually continued. And I want to tell something because Burkholderia pseudomyeli is a condition which causing melioidosis. So the treatment itself is a difficult process. It's a difficult to eradicate disease. So we want to give treatment for the intensive phase and a continuation phases. So intensive phase, the treatment and the drug of choice is actually injection ceftazidime or injection carbapenems can be used. So he was already on meropenem. So we continued the patient on meropenem as he was clinically responding to the drug and the inflammatory markers were downtrending. So we continued the patient on meropenem. And also he is having an extensive disease involving the soft tissue and joint effusion, everything. So we want to add an adjuvant agent to this intensive phase. So we chose doxycycline for this purpose. Actually, the drug of choice which was used in the eradication phase, that is cotrimoxazole, was supposed to be used in the intensive phase. But we chose doxycycline in view of cytopenias were persisting. So at this point, our diagnosis was disseminated melioidosis, including septic arthritis of left knee joint, osteomyelitis of left femur and tibia, pulmonary involvement, that is cavitatory lesion involving the anterior segment of left lung upper lobe, and also pancytopenia, which we attributed at this point to the probably secondary to the sepsis. So I want to just give a brief idea on the treatment protocols in melioidosis. That is, if it's a basic protocol, if there is a skin abscess, patient presenting with a simple skin abscess, first 2 weeks of intensive phase and 3 months of continuation phase is recommended. So now in our case, the patient presented with a deep-seated collection with a joint effusion. So ideally minimum intensive phase of 4 weeks to be given and a continuation or eradication phase of 3 months. But as the patient also had osteomyelitis, we gave a intensive phase of 6 weeks with a continuation phase of 6 months. So these were the trend of the lab parameters I want to highlight. During the course of the treatment, the patient had a persistent leukopenia. That's around 2000. The counts were around 2000. And neutrophilia initially was 81%. It came up to 90% and it was actually falling down. Initially we had the persistent neutropenia was there during the course of treatment. Hemoglobin was also low. Initially it was 10.7 at the beginning of the treatment. Later at the end of the treatment it was like around 8.4. And the platelet count was initially low, 1,27,000, and it came up to 1,81,000, and then it was around persisting between 1,40,000 range. CRP initially was 171, it came up to 245, then it was with the starting of the treatment and the patient was responding, it came down to the value of 8 at the time of discharge. And the ferritin was initially 1,200, it came up to 1,900, and it was downtrending up to 5,450. Sorry, at the time of discharge, the patient was afebrile with he was persisting leukopenia was there, like a 2,600 counts with a neutropenia of 39%, platelet count of 1,46,000 and a hemoglobin of 8.4. And he was discharged with injection meropenem and tapped doxycycline as an adjuvant agent. He was planned to continue the injection meropenem for a total duration of 6 weeks of intensive phase. So when he came to first review, he came with a complaint of left leg surgical site pain, which was actually a small amount of pus discharge was there, and wound debridement, minor wound debridement was done, and the patient was advised to follow up with the report. And he was, at this time also the pancytopenia was persisting, but his inflammatory markers were significantly reduced, so these were responding to the treatment. And we continued the injection meropenem for a duration of 6 weeks, and we planned to start on amoxicillin clavulanic acid in the eradication phase. Only because his pancytopenia was persisting, we could not start on cotrimoxazole. So during the course of review, he had a WBC counts, it was improving slightly, and neutropenia was still persisting. And his hemoglobin improved significantly from 9.7 to 13.2, and his platelet count was also still on the lower range. So this is just a brief timeline of what happened. This is a first admission. He was diagnosed with disseminated melioidosis. Pancytopenia was persisting at the time of discharge. Patient was discharged with injection meropenem and doxycycline. And again, in the first review, inflammatory markers were downtrending, patient was improving, and wound debridement was done, and he has continued on the antibiotics. And in the fourth review, we were actually thought of starting with a cotrimoxazole, that is a drug of choice in the eradication phase, but we couldn't start because we even sought an opinion with the clinical hematology department. But as the pancytopenia was still persisting, we couldn't start the patient on cotrimoxazole. We continued the antibiotics with tab amoxicillin, clavulanic acid, and doxycycline. So in the sixth review, as we was reviewing every month, the patient was improving, completed 6 months of eradication phase, and the antibiotics were actually stopped and the counts were monitored. So again, the patient presented with a relapse. The patient presented with fever, left leg pain in the second admission with a relapse of the disease. So diagnosed with a left upper tibial abscess. At this time, we wanted to start the patient injection ceftazidime avibactam and with the adjuvant agent of tab doxycycline. So we did a repeat MRI left knee, the abnormal marrow signals in the left tibial metaphysis with abscess formation was there. So curettage and saucerization was done and pus samples were sent for culture, which again revealed Burkholderia pseudomyeli, this melioidosis relapse. He was continued on the drug of choice, that is injection ceftazidime and the adjuvant agent of tab doxycycline. So we repeated a whole body PET CT to know the extent of the disease, which showed a persisting infra and supradiaphragmatic lymph node lesions, but there was no interval change in size or number, and also the ground glass opacity, which was usually present, the lung lesion which was present was resolving. So overall image features were suggestive of partial response to therapy. So coming back to the timeline, the patient again reviewed with the intensive phase. He has completed up to 6 weeks with the ceftazidime avibactam and ceftazidime and doxycycline. And at that time also the pancytopenia was persisting. So we started on the eradication phase for the treatment with the tab amoxicillin, clavulanic acid and doxycycline as we did in the first place. So that time also pancytopenia was persisting. And he came to review, then the counts were improving, started to improve. The pancytopenia was slowly starting to improve in the eradication phase up to completing 2 months. So we decided to start the patient on cotrimoxazole. We even sought an opinion with the clinical hematologist, and we started the patient on cotrimoxazole as the counts were improving. But at this time, the patient was slowly developing a monocytosis. So at that time, we repeated a peripheral smear, which was showing a normocytic, normochromic RBCs, thrombocytopenia, and no atypical cells or blast vesi. So we continued the patient on cotrimoxazole and completed a course of 6 months of cotrimoxazole eradication phase, and the antibiotics were stopped. And he was totally clinically improved with the improving counts and also downtrending inflammatory markers. And his counts were monitored. Then on follow-up after 10 months, there's around stopping the treatment, and after 10 months, the patient followed up. He had a persistent neutropenia and a monocytosis and a thrombocytopenia was there. There's a total count of 8.99. There is 8,990 with a neutropenia, severe neutropenia of 9.9% with a 44% lymphocytes and a monocytes of 45% and platelet count of 66,000, hemoglobin of 12.5 and with the negative inflammatory markers around CRP of 1 and ESR of 2. So we repeated a peripheral smear. At this point, it revealed normocytic normochromic anemia with absolute lymphocytosis and thrombocytopenia, and the lymphocytes now revealed a cytoplasmic projections. So we wanted to get a higher opinion regarding clinical hematology. Opinion was sought, and a repeat bone marrow study was done with a chronic lymphoproliferative disorder panel was also done at this time. So the bone marrow aspiration study revealed a aparticulate marrow with showing cells of around 74% atypical lymphocytes, and bone marrow biopsy of hypercellular marrow showing a diffuse atypical lymphoid infiltrates. So I'm just giving an question to you. As anybody from here can answer, what would be the possibility of the disease at this point? We are getting an atypical cells, which was not there initially in any peripheral smear on initial bone marrow. We repeated the bone marrow in view of persisting pancytopenia. So I want to answer from any one of you regarding what would be the possibility for the surprise for this. So at this point, it was suggestive of hairy cell leukemia. Patient was having an underlying hairy cell leukemia. We sent a BRAF V600 EK mutation study. which was a typically seen in hairy cell leukemia, which was negative, which was not detected in this case. So we attributed it to an atypical hairy cell leukemia. So the patient being febrile with a low inflammatory markers, he was planned to start on the drug of choice, that is injection cladribine for hairy cell leukemia. So we decided to repeat a whole body PET CT before starting this cladribine to know as this Burkholderia pseudomyeli, that is melioidosis, itself is a difficult disease to eradicate. So we want to know if there is any residual disease present. So we repeated a whole body PET CT, which was showing a reduction in metabolism of both supra and infradiaphragmatic lymph node lesions. And also there was a persistent FTG, splenic hypodensity, which was there initially, and diffuse increased metabolism of spleen in the entire axial and proximal appendicular skeleton. Initially, these changes were also persisting in the previous two PET CT scans, but we attributed that to the lymphoid proliferation in view of the pancytopenia and the melioidosis infection. But now, retrospectively thinking, we want to attribute it to the hairy cell leukemia, underlying hairy cell leukemia. So the patient was admitted under clinical hematology department and started on injection cladribine, which was administered as 0.14 mg per kg per day for a duration of 5 days. And the time of discharge, the patient was clinically improved, and his lab parameters were also improved with a total count of 4,000 and a neutrophils of 89% and a platelet count of 2 lakh. So here, why this case means, I want to give a take-home message from this case, because disseminated melioidosis, it's usually an unusual presentation which is seen in immunocompromised individuals. And melioidosis itself is a difficult to eradicate disease. And here in this case, there was this patient had no evidence of any clinical, there was neither clinical evidence of any underlying immunocompromised state until the diagnosis of this hairy cell leukemia was made. So initially, the patient had a HbA1c of 7.2, which was, he was not at all diabetic, but initial admission he had a HbA1c of 7.2, but he didn't require any insulin or OHA during the hospital stay, or there was no, on follow-up also, there was no evidence of any uncontrolled sugars. So there could be a false elevation of HbA1c was also there. That's, I just mentioned a few causes like anemia. It could be iron deficiency, vitamin B12 or folate deficiency, chronic kidney disease, high bilirubin levels, chronic H. pylori infection, or smoking or alcoholism can be attributed to the falsely elevated HbA1c at the initial presentation. So retrospectively, when we think, we believe that the patient initially had an underlying hairy cell leukemia, which was manifested as this pancytopenia, and also the disease process of this melioidosis also contributed to the same. And close monitoring of this patient with lab parameters help us to diagnose the underlying hidden hematological malignancy. So I want to highlight the name of this presentation, like hidden hair. So I want to mention it's a just for the interesting purpose, I have put this name as a hidden hair. This hairy cell leukemia was hidden malignancy in this condition.
Thank you very much, Dr. Vinayak, for such a lucid presentation. I was involved in management of this particular case, and I would like to thank the Unit 1 faculty, Dr. Akash, Dr. Shankar, Dr. Vivek, who helped tackle this particular case along with the orthopedic colleagues as well as clinical hematology colleagues. It was a very difficult case. Patient kept following with me back, and probably the kind of follow-up probably would have helped us actually in making this kind of a diagnosis. Till today, while I was actually coming out of the hospital, getting into the car, he was waiting there because he has finished his cladribine and follow-up in hematology, and he was going back to his home town, and he just wanted to see us before he actually went. So it was a very good experience at the end of it, but we had a lot of stumbling blocks throughout the course, and the diagnosis per se was actually a very difficult one to actually get. It's open for any questions. If there is marrow involvement per se in melioidosis as a part of disseminated this one, pancytopenia can be seen. But otherwise per se, it is not associated. It usually occurs by actually having affliction towards the lungs, skin, as well as deep tissues like osteomyelitis presentation here, and also to an extent joints also. Patient was a chemist.
He was a chemist working in Kuwait. Then after this COVID period, he came here. He was working as a security staff in NTPC.
Did he have any environmental exposures? Like usually they have environmental
We
exposures.
has actually went into the history for this exposure and all, but he used to wear boots during his duty hours. There was no contact with the muddy areas or any dirty environment kind of thing.
Most of the amyloidosis, especially disseminated ones that we have seen, actually are all secondary to uncontrolled diabetes. And obviously, as you correctly mentioned, the environmental exposure. But here we didn't have any of them. That 7.2 HbA1c, probably like we have mentioned, is probably something. After that, he had been remaining pre-diabetic. The maximum HbA1c that we have found was about 6. After that, no requirement for OHAs or insulin throughout the hospital stay, as well as even after that. So that is what it was the interesting part, because I think definitely we missed it, but we all attributed everything to secondary to the infection per se, but then finally realized that quite late that it could be a variant of hairy cell leukemia. Why I say variant is because the mutation is actually negative. There are a lot of not so common presentation, because usually it presents with a massive kind of a splenomegaly associated with features and problems associated with pancytopenia. Here that was not the case. It came with actually an infection, and which itself was very difficult to treat. And other part is that this patient responded initially to the treatment, and the pancytopenia kind of improved. And after that, when we looked at the thing, there was a persistent neutropenia, and then subsequently we found monocytosis again, which is something which is unusual in this hairy cell leukemia, because in hairy cell leukemia you find monocytopenia usually. Only in variants you will find monocytosis. So hematology colleagues were telling us that this itself is actually unusual. The patient had to. The treatment itself is very costly, because the agents that were used were actually meropenem and second time ceftazidime, and these things had to be continued for about 6 weeks. Now, I understand, I think your apprehension was probably the PET done, I think probably a couple of times. We had to do it when there was a relapse, because we wanted to know whether we are dealing with something else. And the last PET that was done, the reason why we did a PET was because the hematologist wants to be very clear before they start a cytotoxic agent that there is no residual disease. So this time it was not so much for our indication, but to make sure that patient is completely okay and had no residual disease before starting a cytotoxic toxic treatment like cladribine. Okay, so if there are no more questions, I'll proceed to the next case by Dr. Guru Raghava Lakshmi. This is from Unit 5 by the faculty Dr. Deepu, Dr. Marilyn and Dr. Kiran. I think they have been instrumental in actually cracking this particular case. Over to you, Dr. Guru Raghava Lakshmi.
Good evening, everyone. I'm Dr. Gurur Lakshmi, PG resident, Department of General Medicine from Amritha Institute of Medical Science. So my presentation will be grinds in tendon. Everyone will be wondering, like, what is this topic different, like grains in tendon. So at the end of the presentation, we'll be knowing about what is this grains. So a 49-year-old homemaker from Ernakulam, who is the background of type 2 diabetes mellitus since 10 years and systemic hypertension since 6 years. She presented with complaints of pain in the right upper limb for 1 year and swellings in the right upper limb for 6 months and fever for 3 months. So basically she's had pain in right hand and forearm for 1 year, and she noticed a swelling over a dorsal aspect of the hand, and incidentally she found multiple swellings over forearm and axilla for a period of like 6 months. And then she had developed a fever for 3 months, which was low grade, intermittent in nature, and results on antipyretics. So other than these three complaints, she didn't have any cough, no chest pain, no breathlessness, no loss of weight, no loss of appetite, and no joint pain, no stiffness of limbs, no weakness of limbs, and no numbness also. So her past history, like she didn't have any similar complaints in the past. She's as I already told, this is she's a known case of type 2 diabetes and systemic hypertension on regular medications. So there is no history of any exposure to animals. So on examination, the patient was conscious, oriented, afebrile. Her vitals was pulse rate of 88 per minute, regular, and BP of 130 per 80, respiratory rate of 18 per minute, temperature is 98.8, saturation of 98 in room air. So on general physical examination, there is no pallor, no icterus, no cyanosis, no clubbing, no pedal edema. But she had a right axillary lymph node which was palpable of size 3 into 2 centimeter, which was firm in consistency, mobile and non-tender. No other lymph nodes were palpable. So on local examination of the right forearm and hand, she had a prominent dorsal wrist swelling of 5 into 6 centimeter with ill-defined margins. Actually, this is the dorsal wrist swelling, 5 into 6 centimeter with ill-defined margins and smaller swelling on the olar aspect of forearm of 2 into 1 centimeter. It was firm in consistency, no erythema in that side, no local warmth, no non-tender, and pulse also felt in the right upper limb. So this is the hand of the patient, right and left. In the right hand, she had like a flexion contracture on the right middle and ring finger, and the her movements also decreased. In sense, like when compared to left hand, there is decreased passive and active movements over the right wrist. So other systems, respiratory system, normal vesicular breath sounds heard, bilateral R&D was equal, and no added sounds. Cardiovascular system, abdomen and CNS were normal. So at this point, like patient presented with pain and swelling and fever. So with examination wise, no local warmth, non-tender. And so at this point, I want to consider this patient diagnosis, differential diagnosis as chronic tenosynovitis involving upper limb tendons. The cause might be an infective one, might be a bacterial or mycobacterial, might be an inflammatory etiology, or might be any local soft tissue infection. So coming on to the investigations, a total count of like 8,500 and lymphocytes of 48, hemoglobin of 11.7, platelets of 3,21,000, and CRP was 5.5, but she had an raised ESR of 105 and HbA1c of 11.5, which was very uncontrolled, and RBS of 201, RFT was normal, and LFT also normal, and then electrolytes were in normal limits. So at this point, actually, one of the primary investigation was not revealed at this point to maintain the interest of the case. So coming on to the other investigations, so after blood investigations, we proceeded with basically X-ray of the right wrist. In this X-ray, only the soft tissue swelling was seen. No other bony abnormalities like no joint space narrowing, no osteophytes, and no articular surface irregularities. So next, actually, RA factor and anti-CCP was done, which was negative, and blood cultures were sent, which showed no growth, and MANTO was done, which was negative. And then since she had an axillary lymphadenopathy, we proceeded with ultrasound right axilla, which showed a superficial lymph node of 2 into 1 centimeter in right axilla with preserved fatty hilum and vascularity. And for this patient, they have done MRI right hand in outside hospital. it showed like diffuse hyperintense signals and inflammatory swellings involving the tendon sheets of flexor pollicis longus, flexor digitorum profundus, extensor digitorum, extensor indicis, extensor digiti minimi, and extensor carpi ulnaris. Then after going on through all these investigations, with the help of orthopedics, we did an incisional biopsy from the soft tissue swelling under axillary block. In that, actually, we found rise bodies inside the tendon of the extensor digitorum. So the histopathology report will be synovial tissue infiltrated by chronic inflammatory cells with multiple well-formed granulomas composed of epithelioid histiocytes with Langerhans type of giant cells surrounded by lymphocytes and plasma cells. So the histopathology report, this is a granuloma, and then this is the Langerhans type of giant cells. Then a tissue was sent for MTB panel along with the histopathology. In that, actually, AFB smear was negative, but finally, the gene expert became positive. So basically, this is a patient with tuberculous tenosynovitis. As I earlier told, one of the investigation was hidden to maintain the interest of the case. There comes the investigation, the chest X-ray of this patient. Actually, this patient, this chest X-ray showed a multiple ill-defined nodularities which was diffuse in nature and full throughout the lung parenchyma, and a patchy consolidation in the right middle zone of this of right side of right lungs. So basically, this kind of picture will be most commonly seen in the infective etiology. Most commonly might be in tuberculosis or any fungal if in case of patient is immunocompromised. Other than that, any granulomatous thing and metastasis in this kind of lung picture will be a very rare presentation. So after seeing this chest X-ray, we proceeded with the CT chest, and this CT chest showed essentially lobular nodules arranged in the tree and bud appearance. And then since the patient didn't have any respiratory symptoms as of at that presentation, we induced a sputum. So with that, we sent for the MTB panel. In that, actually, AFB smear was negative, but gene expert came to be positive. So basically, she had pulmonary tuberculosis underlying, but she presented with chronic tenosynovitis in picture like tuberculous tenosynovitis. So basically, my diagnosis is disseminated tuberculosis of chronic tuberculous tenosynovitis with pulmonary tuberculosis. So a disseminated tuberculosis will be involvement of two or more contiguous organs. So after coming to the diagnosing, we have started the patient on ATT of isoniazid, rifampicin, pyrazinamide, ethambutol. Along with that, pyridoxine also given to the patient. On follow-up, she was symptomatically better. And when she came for follow-up, we came to know that tissue and sputum AFB cultures also MTB was detected. So this is actually a case report as similar to this case. This patient also a similar presentation of swelling in the hand. So this is a case report which showed rice bodies taken from the biopsy of that particular swelling. So in this case, I just want to mainly portray about rice bodies. What are rice bodies? Rice bodies are small, loose intra-articular bodies. Why this name came? Because it resembles polished grains of rice, and then these rice bodies will be located either in synovial fluid, bursa, or tendon sheets. This rice bodies is not only seen in this tuberculous tenosynovitis, it also seen in the rheumatoid arthritis, any other infectious arthritis, and bursitis. So basically, these stages are like, if a patient is presenting with tuberculous tenosynovitis, patient will undergo for 3 stages. First stage will be a serous exudate in the tendon sheath. Next, second stage will be a serofibrinous stage, that is rice bodies formation. And third will be if a treatment is, if the patient is not diagnosed, then it will lead to a complication of an abscess formation and tendon rupture. So basically, in this case, what I want to portray in this forum is rise bodies in tubercular tenosynovitis is one of the rare presentation. And then diagnosing a tubercular tenosynovitis is a challenging one, because only out of extrapulmonary TB, that too in particularly in musculoskeletal TB, only 5% will contribute to this tuberculous tenosynovitis. If a patient is presenting with tuberculous tenosynovitis, 50% of the patients, somewhere primary will be there, either in lungs or lymph node, any other primary will be there. So while diagnosing a patient with like this presentation, we should evaluate for the primary source. And then in this case, since she had a disseminated tuberculosis, we start ATT treatment will be 2 months of intensive phase of HR-IZT with 10 to 16 months of HRE will be there. Thank you.
Thank you, Dr. Guru, for such a wonderful presentation. I mean, it's open for any questions to the audience. I think here again, I think we encountered a case where obviously the presentation was completely different as a swelling in the forearm, and then reaching to a stage where I think we found an active pulmonary tuberculosis. Not so uncommon, but we thought we would present this because of the interesting fact of rice bodies and what it signifies in this clinical scenario. So if there are no more questions, I once again thank the API Cochin to actually give us an opportunity like this. Thank you once again from Team Amritha.
Thank you, Dr. Vinayak Sarma and Dr. Gurur Raghava Lakshmi for the nice, precise, extensive worked up case. Thank you, Dr. RENOY A HENRY, for chairing the session.